Okay, how long have you been at the RCH Melbourne? Well, I've been almost 14 years now in Melbourne. How long have you been performing the Fontan operation? I have graduated as a surgeon in '96, but I've been doing pediatric cardiac surgery on my own since '98, and I started doing Fontan at that time. How many pediatric heart surgery do you personally perform each year? Well, in the Royal Children's Hospital, we treat about 650 patients per year. We do 530 bypass cases a year, and for many years we were 3 surgeons. I would say that I'm probably close to 200 patients, 200 to 300 operations per year. Of those surgery, how many Fontan procedures each year? We were doing between 50 and 60 Fontan procedures per year. We had a top at 80 or close to 80 a few years ago. And I think that we were doing around 45 a few years ago in Melbourne. It probably varies between 35 and 45, and I was up to 15 Fontan procedures per year, I think. Do you perform the lateral tunnel Fontan on the external conduit? And what are the benefits and risks of each? So the lateral tunnel was the older version of the Fontan procedure, and the extracardiac is a slightly more recent version. The extracardiac conduit was started in Australia by my colleague Christian Brizard in '96. And progressively from '96 to 2006, everybody in Australia switched to the extracardiac Fontan. So everybody in Australia, since that time, has an extracardiac Fontan, and that's the only operation I do. The extracardiac, there's a little bit of evidence that it is superior than to the lateral tunnel in terms of risk of arrhythmia. So if you have an extracardiac conduit, you have less risk to have fast heart rates, at least if you live in Australia and New Zealand, and you have a smaller risk also to have less slow heart rate, which may be a problem too. And it's a serious problem if you have a Fontan, because that leads to more problem and sometimes failure of the circulation within years, not immediately. But one should realize that the difference between the lateral tunnel and the extracardiac conduit are not huge. They're not very big. So there are differences, but they're not enormous. They're still small. And some people have excellent results with lateral tunnel. The trick with the extracardiac conduit, I think, is that it looks very simple in its concept, because you just connect a pipe to another pipe. But actually, I think it can lead to more distortion than the lateral tunnel, distortion of the lung arteries. So some people have shown that in the US, for example, the people have more problem early after the Fontan if they have an extracardiac conduit than the lateral tunnel. I would say that the debate is still open. The differences are small, and like everything else in cardiac surgery, you should stick to what you do best. If you're good with lateral tunnel, you have good results, you check your results, it's fine. If you're good with the extracardiac conduit, keep going. At what age would this surgery be performed? Well, I cannot give a clear mark, but I think that there is good evidence in the literature now that there is an ideal age of the Fontan. At least it's being clear that you should not delay the Fontan after 7, 8 years old. If you do the Fontan later, it has been shown that you have more complications. You have more early complications, more risk of death, of serious complications like failing Fontan, protein-losing enteropathy, and you have more late risk as well. There's evidence that your exercise capacity goes down more quickly if your Fontan is done late. So you should do it early. Now, whether you should do it at 3, 4 years of age, 2 years of age, the debate is still out there. There are teams, Japanese guys, who like to do the Fontan at 2 years of age. We think it's a bit early to put the large side conduit that we like to put in the extracardiac conduit, but it's open. The one thing that is certain is you should not wait to have the Fontan. You should do it sometimes in early life. How long does the Fontan surgery take? I've done Fontan which were very quick, very easy, no scar tissue, and in about 2.5 hours I was out of theatre. And sometimes I had cases where it took me 6, 7, 8 hours. So it all depends on how many surgeries were done before and how much scar tissue were in. A peculiar issue is the normal surgery as we do it in the children's hospital, because we have a route that is working very well, but the dissection of it is quite tricky at times. It takes adults easily an hour to the operation if you had a normal rather than another surgery beforehand. What risks are associated with this surgery? The risk of mortality in Australia and New Zealand is about 1% the last time we looked. I usually quote a risk of death of 1 to 2%. The risk of early failure, PLE, in particular, protein-losing enteropathy, losing proteins to your gut, is something that may happen. The main issue that is more benign is prolonged pleural effusion, having chest drains are leaking a lot. There seem to be evidence now that if your chest drains are leaking for a long time at the time of the Fontan, that is a sign that your Fontan may, and it's not like it's going to be for everybody, but sometimes may not function as well on the long run. That may be a marker that things may be a little bit more difficult, that your circulation is a bit more difficult. What is the longest lasting Fontan to date in years? Well, in Australia and New Zealand, we get people who had had a Fontan 35 years ago and are still well. There are areas in the world, I think in the Mayo Clinic and in France with the first Fontan, who I've had for a longer time than that. I think that some of the first patients of Dr. Francis Fontan are still alive, so that would be close to 40, 45 years from now. What is the average length of stay in your hospital after Fontan? I would say that it's between 2 and 3 weeks in average. Fontan to transplant. Ahead of the last surgery, the Fontan, we were advised that this surgery would help to give our daughter more time, but ultimately she would require a heart-lung transplant, lungs due to the additional strain pressure they endured because of the Fontan. Is this true? Well, there are no heart-lung transplantation that are done in Fontan, to my knowledge, because even though the circulation may put a bit of strain on the lungs, it's not to the point that you cannot do a heart transplantation alone, rather than a heart-lung transplantation. Now the idea of, if things are not working well, you will need heart transplantation is, again, a simplistic message that has been given to a lot of families. The reality is that has not become true. 1,500, more than 1,500 Fontan done in Australia and New Zealand. We had 34 heart transplantations. So 34, it's not even 3% of those people ending up with a heart transplantation. So it's a rarity rather than a common occurrence. The thing is, likely we should have done more heart transplantation than these 34 patients. There's a few patients, I believe, which we should have offered heart transplantation. That would have been a good option, but the people back off because they're scared of the amount of complications. They're not easy patients. They've been operated 5, 6, 7 times. Sometimes the liver is failing, the kidneys are not so good. and people are scared. People who are not used to this kind of surgery, when these patients are addressed to adult heart transplant services who are not used to deal with congenital heart disease, the people get scared, and so the surgery is not offered. It's the case in Australia. It was the case in Australia and New Zealand. It has been the case worldwide. In the UK and the US, we've seen some phenomena. So, yes, you may need heart transplantation at the end, but you have much more chances that you will not need heart transplantation. The issue is as well is that if everybody needs a heart transplantation, that will be put an enormous problem to the society, because we do not have this heart. We're doing, as I said, about 60 Fontan per year in Australia. We're doing 80 heart transplantation in Australia and New Zealand. 80. So right now we're doing a heart transplantation to between 0 and 2 patients a year in Australia and New Zealand. We cannot bring that number to 40 or 60. That's going to be impossible. So we're going to have to find other solutions. So I've answered the questions, do all Fontan patients require heart and lung transplant eventually? The third question was, I mean, if they reach 50 without it, a transplant, are they sent to the bottom of the list because there is some 25-year-old that also needs it? The way that, it's not a question, but the way that the transplantation list works today in Australia and New Zealand is that the people are listed following quite strict criteria. They really need the heart transplantation to be on the list. Once you are on the list, if you are trouble and you cannot wait, then you can be bumped up at the top of the list. So if you're in a more precarious state, you may get a heart transplantation more quickly if you cannot be supported by a machine, which is a very frequent occurrence now in the adults. The adults waiting for heart transplantation. Now the Fontan situation is a bit interesting because they're a bit of at a disadvantage because they used to have reduced flow into their body and they're quite used to a precarious state. So they don't complain a lot and they don't look that sick. So when they compare to adults who had a myocardial infarction, a heart attack, or a weak heart, well, they seem to be doing better because their degradation is so slow that they adapted to their situation. But also, so that the people tend to wait to give heart transplantation to these people. But also, their kidneys, the liver is deteriorating. So when they look really sick, then they're much more sick than the other patients. And so the big question is, at what stage should we offer heart transplantation? And that's an unresolved question yet. And there's a lot of competition for this organ. So there's going to be a lot of reluctance to offer organs to Fontan patients who may well benefit at an early stage because they will be competing with adults which seemingly are much more sick in the time.